So I continue from just now, follow on.
No, you don't continue from just now. You're
Oh,
seeing me. I'm
okay.
Jenny. I've come to see you,
All
Dr.
right.
Edwina.
Okay. Hi, Jenny. So, I see your father has got quite a remarkable medical history. Um, is it okay if we perform? I ask a little bit more further. Does he have any family history of any malignancies?
Okay, I think Edwina, you didn't get me. What I
Uh,
meant was I don't want you to start from where she left off. I want you to start from the beginning. How would you carry out the consultation?
oh, okay. Can- Sorry.
Right. So your time starts now. Right.
Okay. Good. Morning, Mr. Warren and Jenny. Hi, I'm Dr. Edwina. I'll be your physician for the day.
Okay. Good morning.
Um, Good morning. How do you do today? Are you well?
Uh, uh, yes, I'm okay. I'm okay, doctor. Thank you for
Uh,
asking.
all right. So what are your concerns coming in today?
Okay, I've brought
Or
my
liver disease
father
activity.
because I want you to do a PSA test for him. Um, it's just that I had to leave him outside because he was not keen to come for the clinical checkup to begin with. So I need you to convince him that the PSA test needs to be done.
Okay. Why do you feel like you want to do the test? Is there any concerns or anything that you want to know more based on the test results if we do
Okay,
it?
the thing is, my father's friend passed away 2 weeks ago because of prostate cancer.
Mm-hmm.
Considering his age, I'm really worried. I want you to do a
Mm-hmm.
prostate-specific antigen test for him.
Okay. Besides the prostate specific antigen test, is there any other test that you are keen or you think that would be good for him that you've read online or research on your own?
I'm not really sure, but I did read that prostate cancer is related to PSA, and you can
Mm-hmm.
actually get to know about prostate cancer if you do PSA.
Okay. Yeah, that is true, but there are also other methods that we can also suspect for prostate cancer, which includes physical exam and other blood tests that we can also check just to review his underlying hypertension and diabetes as well. So is it all right if we do it all together?
Yeah, sure, it's okay, no problem. But will you be doing the PSA today?
I will have to ask your father, Mr. Warren, if he is okay. I'll just give him a brief just consult him briefly about the pros and cons of the test, and also just to let him know what is the benefits of it, and what will do we do when we get the results roughly. If the results are positive, what is the outcomes from there, and if the results is negative, how do we move forward? Is that all right with you? To get
Hey,
his
but what do you
consent?
mean by pros and yeah, sure, no problem. But what do you mean by pros and cons?
Because when you see when we take the PSA test, if we get a positive result, it would mean that there is a chance of prostate cancer. We would then need to do further testings like ultrasound, and also a physical exam, which would be done now. But after the test, you would need to do an ultrasound to confirm the size of the prostate, and there is a possible chance of us needing to do a biopsy later on.
Okay. All right.
Mhm.
All right.
Will that be
Okay.
okay with you? And then if there is
Uh,
a positive result, that there is also a chance that it may be false positive, and there's also a chance that your father might feel a little bit anxious if it is a false positive, but we would have to do further checking once we get the results later on. Yeah.
what do you mean by false positive?
Um, when we take the prostate specific antigen, the PSA test, there is a
Uh-huh.
chance of it being false positive, meaning the results may seem positive, but upon further checking, we find that there is not actually any malignancy like prostate cancer. For example, after doing the biopsy later on, and then we find out that there is no cancer to begin with. There is that small percentage of chance.
Oh, is that possible?
Uh, yes.
Oh, okay, okay. Oh, all right.
Mhm.
Okay. So you'll do the test today.
After getting informed consent by your father, Mr. Warren, if it's okay, then we would be able to proceed with the test, Miss Jenny. Once the patient is okay with it, yeah.
Okay. You have 30 more seconds. Okay, your time is up. Right, thank you. Before I ask
Yeah.
Dr. V to give his comment on both the candidates, Edwina, just my piece of advice.
Okay.
When you see you have extra time in an OSCE station, is just
Uh-huh.
goes to say that you have not covered enough.
Okay. Actually, I asked some more, and then my mic was on mute.
Oh, okay.
I'm so
Because yeah, I
sorry.
saw you
Yeah.
went mute. Okay, Dr. V, you're there, Dr. V? Dr. V?
Yep, yep. Can you hear me?
Yeah, are you? Yes, yes, can. Your
Yeah.
comment, please,
Yeah,
on the
yeah. I
two
think
candidates.
two candidates approach differently. The second candidate, I think, cover much closer to answer we needed, right? So whenever you
Yeah,
see these type of patients like that, you must start with a very small talk first, introduce yourself. Then how's your day? What can I do for you? Then Jenny says that request a PSA. Okay. So the question is PSA, but you must ask Jenny, what do you understand by PSA? What must you do? It says, okay, one of friends, father's friend had prostate cancer. Any understanding of PSA first before you start. Then you go to the ask whether there is a need. Actually, men over 50 years old, if they request for PSA, normally you do it. But before that, I think you have to be more careful by asking whether they got symptoms of LUTs. If they have symptoms of low urinary tract infection, like the obstructive and irritative symptoms, then possibly there is some prostatic problems. Then maybe there is better justification to order a PSA. So a patient may be, oh, but doesn't have symptoms of LUTs and all. Then you can tell him quite safely that there's not much of a prostate problem. So basically, that's how you should go about it. Then you ask basically about his history or family history of cancers, things like breast cancers, family history of prostate cancer because it runs in the family. Basically, so basically you should tell the patient that what you normally like to do before you do a PSA. Normally you like to do a DRE first. Digital, see how big the prostate is, whether there's cancer or not. The question is whether your DRE is sensitive enough to detect cancers. It's not. Depend on operator dependent. And sometimes the cancer is too small, you can't feel it. But you just want to feel whether the swelling is very uniform, the middle sulcus is present or not. Then you tell rightly so, the second doctor was saying that there are pros and cons. The problem with false positive and false negative that you should discuss. Very important again. So at the end of the day, is the patient has to make a decision himself after saying that. But sometimes, for most of patients, they don't understand. Tell them it's quite confusing then. Then they say, hey, you're the doctor, you tell me what's best for me. But as required in the protocol, you have to tell a patient about false positive. False positives mean it's high, but the patient don't have prostate cancer. Does it mean that raised elevated PSA means there is the chances of getting prostate cancer high elevated? Maybe, provided sometimes, right? But again, there are other situations where PSA can be raised. Things like prostatitis after sexual intercourse, patient cycles, right? And then UTI, BPH, benign prostate hypertrophy is a high risk PSA. So you must tell patient that raised PSA doesn't means that you have cancer. It is not a diagnosis for cancer, but rather it is specific to the prostate. Anything which sort of affects the prostate can give rise to PSA. Like you rightly say that if a risk PSA, what do you next? Normally at this time, gentleman 72, maybe the level standard, I think about 6. You have to be adjusted, PSA adjusted for age. Young people much lower. Normally the cutoff is about 4, right? So then you have to move to another procedure. Like you say, you have to do a ultrasound, transrectal ultrasound, right? After that, you have to do a biopsy, which is very painful, which is expensive. All these tests are not 100%. You can still miss a cancer. If the cancer is small, if you do the biopsy doesn't sort of hit at the area of interest, then it'll be still negative. But now the latest thing is this MRI, multi-parametric MRI, which is supposed to be more accurate. You can detect more cancers. I think that's the way to go. But it's expensive and it's not available in most centers. False negative means that you have the cancer, but it's negative, right? Then you say no cancer, but later the cancer comes up. The very aggressive cancers normally have a very false positive, a false negative. So these are the things you have to say, because once you're diagnosed as, because you know that most prostate cancers are slow growing. So it is very low levels of prostate cancers. You have just conservative. You monitor the patients. But every month, every 6 months, you have to do a biopsy and monitor the patient. So those are the things. After all what you've told Jenny, the decision is up to the father, whether the father wants it or not. So that's how you should approach, right? To try to cover. The first candidate, I think, spent a lot of time on history. You try to get over it as soon as possible, but so you must know where your focus or attention should be, how you should approach this case, because different cases, even on PSA, focus on different issues. So I think that's basically my comment.
Okay, thank you, Dr. V.
Mm.
All right. I think the next OSCE is similar to the first one, so I'll just read through. No need to do the OSCE. I think we're running short of time also. It's almost 4:30.
We got half an hour more to go.
Yeah. So this one is more or less similar to the explanation already given by Dr. V. Here, the pertinent point is the PSA is 8 grams and you have to break the news to the patient. All right. To let him know, mainly you have to focus on, like Dr. V said, on the false positive and the false negative and the important information that needs to be given to the patient. So, okay. I'll go to the explanation on the request for PSA testing. What are the national guidelines? Malaysian national guidelines on PSA testing, whom to screen, what to do if a patient requests for PSA testing, what PSA levels are required to discriminate between the presence or absence of prostate cancer. Okay, are there any national guidelines on PSA testing? No. All right, why? Because the lifetime risk of developing prostate cancer is 30% and the risk of dying from prostate cancer is 3%. 1,410 men have to undergo screening while 48 need to be treated in excess of control population to save 1 prostate cancer death, and that is not cost effective. Nationwide, prostate cancer screening may reduce the likelihood of men dying from prostate cancer. However, current published data are insufficient to recommend the adoption of population screening for prostate cancer as a public health policy because of the significant over-detection and over-treatment that will result from the screening. Whom to screen? Selective screening of asymptomatic men with a family history of prostate cancer from the age of 40 years and above. Screening interval of 2 years. You stop at the age of 70 years. Patients more than 50 years with voiding symptoms, just like Dr. V said. If the patient is more than 50 years old, has some symptoms and insists that a PSA testing should be done, then you should go ahead with it because the patient has insisted for the PSA testing, especially based on the fact that you've already given them the adequate information. Okay, patients who are on certain types of BPH medication should have the PSA adjusted. Okay, which BPH medications affect PSA levels? Any idea? In the chat, maybe you can answer. Which BPH medications affect? Yes. So you have your 5 ARIs. Okay. 5 ARIs. These are the ones that usually affect PHA testing. Okay. Such as finasteride, somebody mentioned. All right. They cause a 50% reduction in PSA value, which may give patients a false sense of security that could delay a diagnosis of cancer. All right. What to do if a patient requests for PSA testing? Important that men receive balanced information to assist them in making an informed decision. Screening of prostate cancer using PSA test is associated with a high false positive result. Fair level of evidence suggests that false positive PSA testing screening test results are associated with adverse psychological effects. So when you talk about false positive, and that's why I asked, what do you mean by false positive? You have to ensure that you explain to the patient that the PSA testing can be increased. PSA can be increased because of other conditions such as prostatitis, just like Dr. We mentioned just now, exercise, okay, cycling. All right. Okay, I think that's all from me. Thank you. Are there any questions? Are there any questions?
Doctor, can I ask a question?
Yes.
Earlier the OSCE question, right? We had the daughter
Yeah.
coming in. Even though
Yeah.
the patient was outside, can we ask if we actually get a scenario like this, are we supposed to ask all the history and everything with the daughter, or can we briefly explain about the PSA and call in the patient itself to do further questioning? So
Okay.
how will the scenario go there?
All right. Thank you. Yeah, I was expecting this question. All right. The thing is, yes, you actually explained to the daughter the pros and cons of doing the PSA testing because the daughter is insistent. She made it very clear that her father is not interested. All right. And then first of all, to begin with, some candidates, they actually start very nicely by giving that empathy. You need to show empathy to start off with. Yeah, the daughter said that the friend has passed away. So regardless of whether she's related or not related to that friend, show some empathy as a doctor. Okay. That's point number one. Number two, you can also request, can I see your father? Maybe I will talk to him and then we can discuss together. Now, the father is not existing in this case. So the the simulated patient will insist and say, oh no, can please continue with me? Whatever you want to ask, you can ask me. All right. But if the father is waiting outside, then in that case scenario, because you have already covered the net, that's the safety net for you. For all you know, the father is waiting outside. In a real exam scenario, the father is waiting outside. So you can always say, yes, can I please? And the father walks in. Now, had you assumed that the father is not there, which is wrong, you should not assume, then you are in jeopardy, right? So if that case, if you ask, okay, the father is not there, and then the simulated patient insists and says, no, you can ask me, it's okay. Whatever you want to ask, you can ask me. Then you have covered yourself and you can continue with the consultation. I hope I answered your question, Renu.
Yes, sir. Thank you.
All right. Okay. Dr. V, you want to take it on from here?
Yeah, can you unshare, please?
Yeah. Okay.
Okay. So now we do this as single best answers. We got 6 to go. I think we got about maybe 30 more minutes to go. So read it and then I'll put in your chat, please. Somebody read it, please.
A 51-year-old man presents with left flank pain and high-grade fever with chills and rigors. His temperature is 39.5 degrees Celsius and there is a marked leukocytosis on blood examination and pus cells and nitrites in the urine. Allen X-ray reveals a 2 cm radio opaque shadow in the left renal area. What is the likely diagnosis?
Okay, can you put your answers in the chat, please? Can't see it. Anybody? Yeah. 1A. A lot of ones. Some more? Okay, I think most of you got it right. Right, because urinary sepsis because of the obstruction of the stone in the left renal area. Okay. Okay, next one. Somebody read, please. The same person, can you do it? I'm sorry, doctor.
A 60-year-old man has been a heavy smoker presented with gross total painless hematuria associated with the passage of clots. On examination, there are no abnormalities. What is the most likely diagnosis?
Okay, put your answers in the chat. Quite easy, we have gone through this. Okay. You all good. All of you getting the answer right. That means you have benefited from the discussion just now. The answer is 3. Yeah? Okay. Let's go to the next one. Oh, sorry. Okay. Same doctor, please. Yes, read.
An 83-year-old man with significant COPD and ischemic heart disease presents with acute urinary retention. He has had significant difficulty passing urine for the past 5 years and had a similar episode of retention 2 years ago. Digital examination revealed a hard nodular prostate, and on examination, he has a tender bladder palpable up to the umbilicus. What is the most likely diagnosis?
Okay. Any more response? Yes, see a prostate. Very hard, very classical history of finding of hard nodular prostate, right? And the tender bladder palpable umbilicus is because of the obstruction. So you got a bladder distension. Next one, same doctor, please.
A 50-year-old mother of 7 children presented with complaints of wetting herself during coughing, sneezing, or laughter. This problem has been worsening for the last 10 years, and now she is constantly wearing a pad. What is her condition?
Very good. All got correct. Stress incontinence. Okay. Go next one. Okay.
A 3-year-old boy is brought by his mother to their family doctor with a history of increasing abdominal girth. He is otherwise fit and healthy. On examination, the doctor finds a smooth, firm, and non-tender lump in the right upper quadrant of the boy's abdomen. The doctor arranged for an urgent ultrasound, which reveals a solid mass on the right kidney. What is the most likely diagnosis?
Okay. Any more coming in? Good. Still good. Wilms tumor, right? Which is a young boy, otherwise healthy, and is a central finding of swelling of the loin, abdomen. Okay, this is another one. Tired, anorexia with blood in urine. Somebody please read.
Tired, anorexia,
Tired,
and bloody.
Yeah, okay. The other one, give the other one a chance. Thank you, doctor. So anybody want to read?
Okay, yes. Tired, anorexia, and bloody urine. A 15-year-old male presented with complaint of dark-colored urine. 3 weeks ago, he had sore throat, which recovered after buying some pills from nearby pharmacies. 3 days ago, he noticed that he was passing out urine, which looked like coffee. For the past 2 days, he feels tired and has loss of appetite. On examination, his BP is 145/90 and a mild swelling of his legs. The urine analysis reveals gross hematuria with groups. Microscopy is positive for red blood cast.
The most likely diagnosis for this patient is, I think we have discussed that with Dr. Zinet.
Yeah.
Right? So you all got it right. C. Post-streptococcal glomerulonephritis. Very good. Then you all shouldn't have problem. Very good. Well, let's see. Okay. Continue reading, please.
Yes, what is the likely outcome of this condition? Most patients eventually develop to end-stage renal failure and require dialysis. Option B, the prognosis dependent on the severity of causative factor. Option C, most patients will recover within 1 or 2 years. Option D, antibiotics will shorten the recovery period. And option E is nephrotic syndrome is the least common presentation.
Yeah, let's see how this goes. Right, good. Most patients will recover. This is quite self-limiting, you know. Actually, very good outcome for children, right? So adults are a different story, but the children, very good outcomes.
The most common cause of renal failure among those listed below is congenital anomalies, polycystic kidney disease, hypertensive kidney disease, diabetes kidney disease, and chronic pyelonephritis.
Dr. Nurul Iman, you said is C. Can you please comment on it?
If I'm not mistaken, it's the number one statistic in Malaysia, hypertensive cause of kidney disease.
I think a lot of your friends have a different answer, D. I think your diabetes mellitus. The patient on dialysis, what are the main causes of patients who undergo dialysis? A lot of diabetic patients on dialysis. So I think diabetic is hypertensive, yes, but I think most diabetic patient has the problem is kidney disease, and some of them end up in nephrotic syndrome. Okay. Okay. Can read, please?
Which hypertensive agent is contraindicated in patients with chronic renal failure?
Is your answer D? All of you D? Is it true? Oh, B. Okay, someone say B. Okay, somebody beg to differ. B. Any more? D. Okay, so there is varying views on it. Dr. Henry Wong, what do you say is B? Please unmute, Dr. Henry Wong. The B, the one who says B. Henry Wong.
Sorry, doctor.
Yeah, okay.
I think hydrochlorothiazide is bad if CKD is if GSR is less than 30, the hydrochlorothiazide become less effective.
Yeah, but it is not contraindicated. Is it contraindicated? You can still give, can't you?
And then with the electrolyte imbalance also causing.
Your answer is right, but your explanation is not incorrect.
Oh,
Right. Have you seen this combination of hydrochloride triamcinolone?
no, doctor.
Things like diuretic, I think so. They complain with one is potassium sparing, triamcinolone. It is both of these two are diuretics, but triamcinolone sort of preserve potassium. Okay, so what happened in patients with CKD? They tend to have high potassium there. So when you some the problem also with ACE also they're worried about. That's why patient with ACE, remember, you start patient on ACE or ARB 2 weeks or 1 month, you do the serum potassium and secretin and see how the levels are, right? So if for ACE, because of bilateral renal artery stenosis, because of the poor circulation, you have a raised potassium, a raised secretin, and also decrease in GFR. This combination, hydrochloride triamcinolone, is a very old combination. I think, I can't remember what there's. There's one called diuretic, which combines these two. But this totally is contraindicated for CKD. It raises up, it causes hyperkalemia. Okay? Okay, somebody continue. Dr. Wong, can you please read this?
The major cause of death in chronic renal failure is.
Okay, put in your answers, please. Some A, some D, A, uremia, E, okay. Quite diverse, huh? D, A. Okay, those patients on dialysis, normally, what do they die of normally? What really sort of increase the mortality, right? Dr. Rosling?
Yes, Prof.
Yeah. What causes normally you see a patient? Main cause of death?
In end-stage renal failure,
Yep.
would be due to thrombosis. It can happen. It can cause myocardial infarction.
Yeah, myocardial infarction is the main cause, isn't it? Uremia, I thought a lot of patients can go for years, on dialysis. They don't die of uremia. They can have complications of uremia, osteodystrophy. But the thing is that because uremia, the calcium levels goes up, the arteries get blocked up with calcium plugs, and most of them succumb to myocardial infarction. Hypertension, yes, maybe. Malignant hypertension because uncontrollable. Ischemic stroke, they are predisposed to. But the thing is, the main major cause of death, all of these can be the cause of death. But the main cause is myocardial infarction, right? Last one. Can you please read the question? This? Somebody? Dr. Rus, please unmute.
The anemia associated with chronic renal failure is hyperchromic macrocytic, hyperchromic or normochromic normocytic.
Okay, put your answers, please. Any more? Any other answers? Well, I think getting less and less. You guys are getting tired of it. Okay, quite good. That's right. Normally it's normocytic, normochromic. But later, because of malnutrition, they can have hypochromic. Oh, the iron deficiency anemia. But normally, this anemia of chronic illness, normally is normocytic, normochromic. So I think we come to 4:50, I think. Any more questions before we call it a day? Questions? I think we must have a long, tight day. So most of you are quite exhausted. Any questions? Any more questions? Because I don't want to go through another one. You all, I'm in for maybe a bit of ultrasound, or you just want to call it a day? Comment, please. Oh, you're thank you already. You say thank you already, that means I think you all must be tired, okay? So I think it's quite fun for both of us to co-present. I think you guys have been quite good, pretty good. I think quite impressed with the answers you gave. Actually, I think Dr. Zina could attest to that. I think from our experience conducting workshops, I think this is, I think your response, your positive, correct answers are pretty good, pretty impressive. So keep at it, keep on studying. So we hope that you can pass your part 1 and join us in part 2. Okay, Dr. Zina, anything to add?
No, I think that's all. I think this time around the online session has been really good.
Good, very good, very good.
It's so good, yeah.
Very good, very good. I think
the
the answers has been quite positive. I think the response are there, even the multiple choices.
Quite interactive.
Quite
They do
good. I think
respond
the candidates, the quality now is getting better as compared to the previous years. So I'm very hopeful that you guys will do very well in your exams. So we'd like to thank all of you for being there, and we hope all the best. Okay, bye. So we'll sign off now. Thank you very much. Thank you, Dr. Sinet. Bye. Yeah.
I'll see you tomorrow, Dr. Wee.
Oh, yeah. But hey, tomorrow's the case, not the many. 24 candidates only.
No. 42. 42. Physical. Yes.
Okay.
Physical.
Okay, then. Okay. Then we have some fun then. Okay, thank you. Bye.
Yeah.
See you then tomorrow. Bye.